Hi, I'm Spencer Krause. I've been building robots for over 20 years. In that time, I've seen a lot of interesting things, and I've heard a lot of interesting stories. Collaborative with Spencer Krause is a place where my colleagues and I can relax, crack a drink, and talk about some of the crazier things we've seen at work and some of the experiences we've had that have gotten us to where we are today. Subscribe today to join the collaboration. Welcome to Collaborative Podcast. I'm your host, Spencer Krause. Our guest today is Ken Urish. Ken is a research physician at the University of Pittsburgh Medical Center here in Pittsburgh and an all-around great guy. Ken, welcome to the pod.
Hey, it is awesome to finally be able to come back.
It is great to have you back, buddy. It's been a while.
Well, I am looking around here, and you are definitely living the good life now. We have gone from a garage to like a formal studio.
Yeah, it keeps upgrading. We'll see if we ever make any money on this. Maybe we'll go up another step even after that.
Yeah, I would have been fooled. I would have assumed that this is a highly profitable operation.
We have a couple of sponsors. One of them is SKA Robotics.
I love that.
We've received sponsorship money from 4 organizations if you count a one-time sponsorship. And 2 if you look at our regular sponsors.
Oh, that
which
is
are
awesome.
SKA Robotics and Rockwell Park, which is where we're filming this.
Yeah. They do good tools.
They do good tools. They did good tools. Now they do good real estate. So what are some of the things you've been up to? Since you were like guest 10 on the podcast or something like that. I probably get the number wrong, but now we're on episode 180 something. It's
wow.
Good. Yeah.
So I'm finally being able to make I feel this is almost like an SNL SNL season where it's like you're in the beginning, you're like, they finally let me back on.
We can still ban you forever.
Yeah.
No, I'm kidding.
Yeah, no. So still a lot of the same stuff. I'm an orthopedic surgeon, do hip and knee replacement. I like to joke around that about 100% of my time is spent in the clinic taking care of everybody's problems with their hip and knee. And then the other 100% of my time is up in the lab, trying to figure out other innovative solutions to help those problems out. One of the big areas, that this is sort of how we initially met was using robotics with surgery to improve what we do in the OR.
Yeah, and I really treasure that cadaver lab that we went to. That was so much fun. I really enjoyed it. I learned a ton. And, that was fun, some of the projects we've gotten to work on, either directly and indirectly over the years there. What's some of the trends you've seen recently in robotic surgery? I guess maybe just since, you and I have even worked together on it. Yeah, no,
so you have all these different fields inside robotics. Or inside, you've got like the GI surgeons doing all the stuff in the abdomen. You have the thoracic surgeons taking care of all the stuff in the chest and the heart. Neurosurgery, so orthopedics, we do, most of the limb stuff. Plastics with all the soft tissue. And, from our perspective, robotics and orthopedics is very unique because you have certain systems that are really capable of handling different soft tissue stuff, like the Da Vinci, where they're doing stuff with GI or with urology or whatever. But then orthopedics, because it's primarily doing a lot of work with the bone, it's its own completely different setup. And so it's been actually just a lot of fun to see how it's grown and developed over it's been like 7 years now?
7 years since
the first podcast.
Something like that, yeah. It's been a while.
Yeah.
I think less than that because I think I started during the pandemic. It's 2026. It's like 5 or 6. Yeah, it's still a while.
Yeah, it's a long time.
Yeah, for sure. Do you ever mess around with like other surgery robots outside of ortho just for fun? Like, you ever go in the Da Vinci just to give it a spin?
But it's interesting. So to use the Da Vinci in most places, and I could be getting a little bit wrong with this because this is not my area of specialties, but you have to be sort of officially signed off.
Oh, okay.
And then so to practice, they have all these different like little simulators and models where you can kind of work with it, but you have to do something with like, putting a ball in a cup or, some kind of, or practice sewing. And I look over at where they have those simulators and I was like, that'd be a fun thing to play with.
Yeah, it's in the physician's lounge, right, at McGee. I mean, they still have it there.
But I have not played with it.
Fair enough. I got to play with one at the Anahist Gymnasium at UT Austin. And
Oh, wow.
I did not have very much dexterity with it. I wasn't great. But.
Yeah, it's there's a lot to be said that goes in with just, it's like it's a surgical truism of, it's not that you show up and you just know how to do it. It's just raw practice. It's the repetition over and over and over, just to learn how to do that new skill.
That makes a lot of sense.
No. Yeah. So most of the stuff we're doing with robotics right now, it's kind of an extension of what we were working on 5 years ago. How do we use, so I do total knee and total hips. I have a really big interest with robotics and total knees. And so it's, how can we use this to do a total knee better? And then how can we kind of expand on the technique into new areas?
That's awesome. And the last time you were on, you talked a lot about just improved outcomes on the long tail. So
yeah.
Often you don't even know how much better it is. I'm just recapping for our guests here until, 15 to 20 years later, and then you can trick, kind of the improved outcome you got from using a more precise tool. What are some of the innovations you're seeing like now, like in the last, just the expansions on what was being done, 5 years ago or so, when I last poked my head in that field?
Yeah, so some of it is more of a development of what we were already working on, and some of it is some sort of new ideas. When I first got involved with robotics with total knees, it was primarily doing a partial knee replacement, because technically that's a harder procedure to do. And then there's a group in town, Smith and Nephew. They actually, it was a spinoff from Blue Belt out of Carnegie Mellon. And they expanded that out into do total knees, and so it's how, when we're doing a total knee, like sort of where, because it's sort of a new area, where are we going to try to put the implant? Like what kind of, we call it soft tissue balancing. Like how are we going to try to where should we be putting this? How should we be altering our technique when we're doing this? And so it's really grown from there, from the perspective of, how, if I have one person that has a knee that's maybe has a little bit more soft tissue laxity to it, it's a little bit more loose, versus someone, I call them the Wreck-It Ralphs, like they're just real big brawny, strong, like just engines, we probably should be doing those a little bit differently. And like, how are we altering this to give it like a little bit more of a personalized outcome?
What are some of the things you do? Like if somebody's like, I guess, kind of obese versus muscular versus kind of scrawny, like how does it make a difference in your technique or just your considerations?
Yeah, well, that's, so the special, it's interesting because, when you're talking with the residents of the fellows, you show up into orthopedics and you look at a total knee replacement as being, putting an implant and resurfacing the bone, and so that you're doing a joint replacement. Like, like the layperson has this idea sometimes that, you open up the knee and you take like the whole knee out with like an engine crane, right? And then, you have like this like joint that's like a big piece of metal, and like, you just like, you drop it back in and like you bolt it on and you're set to go. But it's really more like a resurfacing procedure where you're only taking a few millimeters of bone off of each of the surfaces, so that you can put, if you take 10 millimeters of bone off, or 5 millimeters of bone off, you're putting something that only has a thickness of 5-10 millimeters or something like that. It's not really that big in terms of its overall thickness.
And this is a total knee implant.
Yeah, total knee implant. And so it's really like, it's like cabinetry making. Like you're only taking like a little bit of the surface of the bone off around it. And so the big thing that people have been like, we think about are, well, you need to do these soft. So people kind of approach this like it's this like, well, how am I going to do my steps to do these bone resections so I can put the implant in the right way? But the really hard part to master and to learn is, how am I going to be doing these different soft tissue releases, or how can I avoid doing soft tissue releases to really kind of give them the kinematics that they had before? That's going to give them, that's going to really, that's like the secret sauce in all this. Like that's the hard part to figure out. And so there's a really big interest in sort of this functional recovery that we've been working on, where, well, yeah, we know that they're doing better than they were before, but, from a functional perspective, if we put it in this way, can we measure these big differences in the activities that they're doing afterwards?
That makes a lot of sense. So, I mean, does a physical therapist just take notes, or how do you get feedback on that?
Well, it's actually so I'm over at the University of Pittsburgh, and we're lucky because the physical therapy department is actually they're really top ranked program, and they're very good at looking at outcomes. So they actually it's literally it's a lab where they have these very precise way, like you're going to walk 10 meters. We're going to have you get up and, do this, and you're going to sit back down. Or like, how long does it take you to sit up and, get up and down a few times? And you measure what they're doing. So instead of like these, on a scale of 1 to 5, how do you feel right now, which can be very imprecise.
Sure. Totally subjective.
Yep. Now you can say, well, gosh, like, it took me before surgery, it took me, I don't know, like 15 seconds, 20 seconds. Oh, it's probably a lot longer than that, like 25 seconds to walk 10 meters. But now, look, I'm walking that much faster than I did before. And you can see also how they progress. So, now it's like sort of two edges. You're looking at where do we ultimately get them, and can we get them there a little bit faster? And so there's becoming a bigger focus now on just overall with the kinematics, like how can we really restore what was going on there before?
And if you displace less soft tissue, your healing time goes down, and so they can get back faster?
That's the thought. Yeah, that's the thought. So a classic total knee, we talked about having a neutral mechanical alignment, right? So if you think of your femur going down, your hip going down to your ankle, you wanted it like a straight line. And you didn't want any bend at all in your knee. We call that varus valgus, or your bow-legged or knock-kneed. But usually people show up, and they have just a few degrees one way or the other, right? And you can see if you look around at somebody who has really bad arthritis, sometimes you'll see like 20-degree deformities. But
oh, wow.
Almost everybody has just a few degrees. Like, we naturally kind of go like, and so like you're naturally almost in a little bit of, just a little bit like just a few degrees, not a lot, just, something just to kind of be there. And
is that the femur actually deflecting, or is that more at the
joint surface?
At the joint surface.
Yep. Like, okay. So they kind of come in, if you're on, you kind of, it's kind of hard to do it, but you're coming in like that or something.
Got it.
Yep. And so the goal initially, and this is like back when this was all getting started, is let's put it in so it's exactly at 0 degrees, right? There's no deformity whatsoever. And what we've sort of slowly learned is that a little bit of deformity probably isn't a bad thing, just a few degrees. And when you were doing all this without a robot, you want to do, some of the reason why you want to do a neutral alignment is that you want something to be perpendicular at 0 degrees because you can see that. And this is a really interesting robotics problem. It's amazing how you can see symmetry with your mind's eye compared to like, you can look at something, and if it's 2 degrees off, people are really good at seeing, wait, that's not perpendicular. Like if we're trying to look at a square, or well, it ends up being a rectangle, wait, that's not a rectangle. That's really more like a trapezoid. And the solution was to try to do that with the bony cuts and having it as, perpendicular to whatever you were doing as possible. But, if you've got with the robotic tools now, you can accurately say, I want to put this 2 degrees a little bit off axis. And so we can use those bony cuts now to recreate, to kind of like not to recreate, but to solve some of the issues that we had before, to get something a little bit straighter, or to make that space a little bit more rectangular for us. So you're almost putting in like 1 or 2 degrees off to solve whatever deformity you had before. Or, to keep yourself, like if you're showing up 2 degrees off axis, but we're going to keep you about 2 degrees. And, we've learned that and this is, this is the stuff we're trying to figure out right now. But
if you're 20 degrees, maybe take it down to like 3 or something.
Well, this is where, this is like, then this is like the completely, off topic here. There's a group of people that have always argued that you can do that, and maybe it works well. And then there's an entire camp that says like, that's crazy talk. What are you doing?
In terms of?
Well, so if classically, if you put something 20 degrees off, we were worried, how long is this going to last?
That's fair. I was more talking about like the arthritic patient that came in 20 degrees.
Yeah, 20 degrees off. Yeah, no. And then some people argue, no, and there are a few groups that say, no, like we'll put them in, we'll keep them there because they were happy. But if you look at the data from a decade ago, if you were doing this with manual instrumentation, and you had this 20-degree deformity, like
You would have tried to neutralize it.
yeah, and so and it's like one or two groups that are like, no, like it's the robot has made it a little bit easier to measure what you're doing with that, and so there's a lot of so it's interesting how
Oh, so it's really up to the surgeon. You might keep them at 20 degrees, or you might.
yep yeah, but it's that is a very small population of people that are doing that versus like the overall thought process of, we're trying to get this at plus or minus 3 degrees. And so they call it like sort of like a restrained alignment, right? So instead of being completely crazy and being 10 degrees off, we're going to give ourselves a few degrees to work with, but we know we can do it accurately because we have a robot measuring like where we're putting all this stuff so that when we try to execute that plan, we're going to get there.
Did you know that Collaborative with Spencer Krause now has a merch store? Please go to cwskmerch.com for the latest in CWSK styles. We've got hoodies, t-shirts, hell, we've even got whiskey glasses. Everything in the store has custom art that our team worked really, really hard on, so go ahead and show your support for them, me, and the rest of the CWSK team by going to cwskmerch.com today. Better yet, support yourself and use discount code PODCAST10, all one word, all uppercase, for 10% off your entire order. Thanks for your support and enjoy the rest of the show. Collaborative with Spencer Krause is sponsored by SKA Robotics. If you're in the market for elite field robotics expertise, please consider hiring SKA Robotics. They sponsor this podcast and solve some of the toughest engineering problems in the world. SKA Robotics can be found at skarobotics.com. When did you know you wanted to do it? Like, kind of at what age did you decide, I think I'm going to be a surgeon?
Oh, yeah. It's interesting. For whatever reason, I was always really interested in medicine. No idea what I wanted to do in it. Went to college, and it was everybody on my mom's side was an engineer, and I realized, wait, engineering's really cool, but like, how do you do both? And I'll never forget. It was a college interview, and they're like, oh, like that's bioengineering. I was like, oh yeah, bioengineering. That's what I would like to do.
The word I've been looking for.
Yes, that's awesome. And it was sort of a newer field at the time. It was longer ago than I would like to talk about. But I was like, yes, that's what I would like to do.
That's how I felt when somebody told me what mechatronics meant.
Yeah, and I forget what we were talking about before, like one of the boards of some sort. Anyways, and so got into the bioengineering, learned how I could take that into medical school. And wasn't quite sure what I wanted to do, but all of my grad school stuff when I was getting my PhD, I was really interested in regenerative medicine and building things because that's what engineers do. We like to solve problems and build things. And at the time, adult stem cell development was becoming a much bigger field, and I was like, "That's really cool. That's what I want to do." And the lab I worked in just happened to do orthopedic stuff. And I was like, "Okay, well, I'll check this out." And became really interested in cartilage and muscle and bone regeneration. And so you had all these orthopedic residents coming through. And I said, well, so I ended up doing a med school rotation because I was hanging out with all the orthopedic residents, and they seemed like they were a pretty cool bunch. And I'll never forget, it was fixing a hip fracture, my very first orthopedics case ever. And I'm like, this is awesome. And I've learned if you take an engineer and you put them into a OR with an orthopedic surgeon, it's like shooting fish in a barrel. because this is what orthopedic surgeons do. Like, you have a problem, we're going to fix. We're going to use these engineering techniques and these tools, and we're going to fix the problem, and you're going to be good to go. Like in general. And so that part works. I mean, it's so much fun to be able to work with your hands, solve a problem, and fix it.
That's awesome.
Yeah.
It's funny because, my dad was an ortho surgeon, as you know, and I decided to be an engineer. So
they're really, really, really similar fields.
Yeah, I guess I could see that. He did tell me I should become a surgeon because I like working with power tools.
Yes, but no, like that's what we get to do all day. It's like that's sort of like the stereotype of the orthopedic surgeon. Like we drag our knuckles and we play with power tools. But it's a very this kind of gets back into the robotics. It's a very different tool set than what you'd see in a lot of other ORs. Like we use a lot of the same instruments that they do, but we have this entire other set of tools that we're working with, because you're doing all this stuff with a completely different material, bone, right? Like you're never going to see a general surgeon or a plastic surgeon pull out a drill or a saw, but we get to use this stuff every day. It's so much fun.
That's awesome.
Yeah.
What are some of the more interesting tools that just other types of surgeons besides orthos don't get to mess around with?
Oh, you mean like in terms of like
I mean, I guess like for me, like a suture anchor comes to mind, or like I don't know if that's.
Oh, I see what you're saying.
Yeah.
Actually, so the biggest thing you learn with all this stuff is that the tools that we get to work with in the OR are so much nicer than your home tools, right? And so my big goals in life are like to get like a set of the surgical power tools, like I can use like for like my home improvement projects, right?
What's stopping you?
Yeah, money and expense.
Yeah, that makes sense. And my dad said the exact same thing to me. He's like, yeah, it's like the stuff you have at home, but just way nicer.
Way nicer. And actually, one of the other things that you learn a lot is, when you go into the OR, you need to have a really good reason to be there. And so we're not trying to just take all day to get a job done, right? Because there's a level of risk that goes along when you have somebody under anesthesia. No matter what we do, no matter how much we try to optimize this and de-risk it as much as possible, the longer you're there, it's inefficient for your time. It's, having something take 3 times as long as it should just is going to increase the problems that you could run into later on. And so, that's why you have an entire team there, because they make it more efficient. And the biggest thing I've learned with doing stuff in the OR versus trying to do some type of project at home is how much more efficient you become when you have an entire team helping you out to execute something, right? Like if I'm, going to do something at home where we're doing like this, some type of woodworking project with one of my kids, it's going to take all afternoon. But, if you've got a team set up where like, this is what the plan is, this is the equipment that we need, we have it already set up and ready to go in the OR. You walk in and you can get something done in 10 minutes very quickly because it's all there. It's, you have a team, you have a plan, everybody is working well together, and you know what you need to do.
That makes a lot of sense.
Which is, only more frustrating when then you go home and you're trying to get something done. And, it's 5 hours later and you're like, I have accomplished absolutely nothing. But it's because you don't have a plan. You don't have the right team. You have to like, I'm missing this. I'm going to have to go back out to the store and get that. It's like the same thing with cooking.
Your 8-year-old didn't follow their checklist.
Yeah, no, but
which doesn't exist.
Yeah, no, but it's like people are like, how can you do like? It's interesting because I can do a knee replacement a lot faster than some of the really simple procedures because you have a team there and this is all they do all day long. And so you step out and you're like, okay, this other thing has shown up. It takes just as long to do that because this isn't something we do every day. And it really reinforces the importance of having a plan and knowing what you need to do and have everything ready to go. And people, when you're talking to a patient about this, you're like, well, it's kind of like cooking. If you have this really complicated dish that you do, but you have all your ingredients out and everything is there and you've done this a lot of times before, you can get it done really quickly. And then you do a new recipe that's a whole lot simpler. Oh, I forgot the eggs. I got to go, we don't have enough. I have to go to the store, or like, where is that little piece of equipment, or where is this bowl? And now I've got to clean it off. It just takes a lot longer to do.
So what's some of the other research that you're working on in your lab?
Yeah, no. So, one of the big focuses of what we look at is, knee and hip replacement, one of the most common major surgical procedures in the United States. The biggest reason they fail overall is for infection. The important kind of footnote with this is that the overall infection rate with these cases is 1 to 2%. Knees and hips work really, really, really well. However, the most common time that they're going to fail, and which is from a relative, an absolute perspective, very tiny, but from a relative perspective, the biggest reason they fail is for infection. And so I've always been really interested in, well, how can we improve how we treat these? Lots of different work in sort of new approaches. So like there's a new class of an antibiotic that we've been trying to help develop that's going into clinical studies right now.
Cool.
there's some other work with like different ways to do some of these chronic infections where you can do different types of antibiotic delivery. And then one of the other really cool things we've been working with is bacteriophage. So it's sort of like basically a virus, but it's only for bacteria. So this is like in very, very, very specialized cases where they've just failed treatment after treatment after treatment, and like you have nothing else left to do. Like how can we use a virus for the bacteria to try to like help at least kind of control the infection for a little bit?
That's really interesting. What are some of the antibiotic delivery mechanisms you're working on? And that's just being a dumb mechanical guy. I feel like I get my head around these days.
Well, the new class of antibiotic that we've been working with that we've helped out. It's a company called Peptologics, and it's basically it has activity against biofilm, and so their interest now is using this in acute infections where you're trying to get clean as much of the biofilm off as possible. Can we use it in these cases to improve outcomes? And they did their phase 1B and got some really great results of this, and they're getting ready. They're starting their phase 2-3 now. There's another company, Osteel, where this is a different set of infections. Now it's a little bit more chronic, and you have to take the implants out. Is there a way that we can improve how we sort of get the antibiotics in there and speed up the process? They're getting ready to kind of they've finished up their FDA studies, and they're kind of going through their process right now. And then like we talked about the bacteriophage. So this is like the salvage cases that are in really bad shape where, they've failed everything else, but you're trying to salvage your implants. Like how can we, what can we do here now to at least try to save it? Like these are the organisms where, the antibiotics don't work anymore. Like, so you'll have certain organisms where it's a classic example of the bacteria where there really aren't good antibiotic options. You read about this in the newspaper where, go ahead.
Just some resistant bacteria that just gets away from everything.
Yep. And now if you have an IV antibiotic, it's really hard to find a bacteria where there isn't an IV antibiotic that's going to get rid of it. But you can't be on an IV antibiotic forever. And so if you've got this infected implant where the infection's not going to go away, we have to have some type of option you can take orally. And then now there are these different organisms out there where there aren't
chronically you have to do that forever?
Well, yeah, because so if this is this is a very special case for these salvage for these infections where the implants are really big, and your next step is like, do I need to worry about like not being able to get an implant back in there? Or like they've had so many different surgeries that it's reached a point where there aren't any other options to reconstruct their joint.
Wow. So this is like revisions on revisions.
Yeah,
on revisions.
Like this is like really this is a very specialized set. And you're worried, well, like if I take these implants out to try to get rid of the infection, then that's not going to work very well, and they're not going to be able to walk, or they're going to have a huge loss of mobility. And so, but if you've got the bacteria on the implant, like this is what we work on, the biofilm, right? This three-dimensional structure of the bacteria, you're not going to be able to get rid of that with an antibiotic. The biofilm is really tolerant to the antibiotics.
So that's just because it's kind of isolated from like your biology. So even if you circulate, IV antibiotics through your bloodstream, it's like over here and it just can't get at it.
It becomes an interesting engineering problem. Even if you put this like atomic dose of antibiotics right on top of a biofilm, it takes a few days before you're going to truly eliminate all that bacteria.
Because it's got to permeate the biofilm?
You could even get, that's like a mass transport problem, right? You could even like overcome that mass transport because now you have this huge concentration right above, right in the solution, right on top of it, right? So you've overcome the diffusion part. But what ends up happening is that so the classic example is like penicillin. Penicillin disrupts cell wall synthesis.
Okay.
And so if you're metabolically dormant, and we call these persisters or dormant, or there's a whole bunch of different variations of what we'll call it, but if your metabolism has been decreased inside the bacteria, it doesn't matter how much penicillin's running around, because most traditional antibiotics will work on disrupting some type of metabolic process.
But if the metabolism's so slow that it's not even creating new cell walls and it's just kind of dormant, then it's not going to do anything.
It doesn't matter how much penicillin's there. It's just the bacteria is going to sit there. Then at some point, that concentration is going to decrease a little bit for whatever reason. The bacteria comes back online, and it can make as much cell wall as it wants to because the penicillin is not there anymore.
I shouldn't laugh at that, but it's making sense.
Wait, no, but so that's like the
You're
hard
good at
part.
explaining it.
Yeah, no, but that's the hard part about this, because people go, well, I've got this infected implant, and this is a knee, but it's like you could take. There's a lot of things in surgery where we're using some type of implant or device, and if it becomes infected, the bacteria sort of sets up shop as a biofilm on it. And they're like, well, why can't I take an antibiotic? It's because it's so tolerant to the antibiotics that you're never going to get rid of that infection.
So like the dormancy is almost like an evolved response in some bacteria in order to avoid getting killed by penicillin.
Yeah, or the antibiotics. Like it's not even like an evolved response. It's just you're not like it. I mean, this has been going on for thousands of years, but it's just you're not going to get rid of it.
Yeah.
So the only way to get rid of the infection is not an antibiotic, but you need the surgery part of removing the implant.
Wow.
And so if you've gone down this road of multiple surgeries, you're worried about how well you're going to be functioning afterwards.
So like straight up abradement, or like do you have to like scrape everything off after you remove the implant, or?
Well, once you remove the implant, then now you just have your soft tissue structures, and you do a debridement. Yep, you clean all the bone surface off or the soft tissue structure. You're looking for like where could there be some stuff that doesn't look as healthy as it probably should be, and we're going to take that out. But you need to put a new implant back on. But kind of getting back to your thing, with the salvage cases where you're trying to save that implant, if I'm not taking the implant off, then I'm not going to get rid of the infection. So I have to have some way to control that. And that's why you're on an antibiotic for a really long period of time.
Yeah, that's brutal. So you effectively have to remove the implant. You have to be on an antibiotic for a while without a functioning knee. And then you have to do like a reconstruction, like I would imagine a decent amount of time later. Like you can be in the hospital for weeks or months.
Months.
Wow. So you're just bedridden for all those months while you're effectively waiting to clear the infection.
So in these chronic infections, when you're trying to take everything out, we'll do something we call a spacer. This is sort of like a traditional way to approach this, where you take the implants out. You have something to kind of hold the space in there. And, I call them, they're sort of like the spare tire if you get a flat. It doesn't work as well as your tire, but allows you to kind of get along and do what you need to do. And so in these chronic infections, we call it a two-stage. You take everything out, right? That's to really try to control the infection. You get this large dose of antibiotics. And then we'll do what we call an antibiotic holiday for a while, where you just kind of take them off the antibiotics. They have the spacer in place already, and you're looking for signs that the infection's gone, right? And like the biggest one, the easiest way to describe it is all the tests that we did before to show, look, it's infected. Now all those tests are negative. And then we go back a few months later on, and you take your spacer out and you give them the new implants. And that's sort of how we control those chronic infections. But if you've done that 2 or 3 times, you don't have as much bone stock to work with. And so you can't just keep on taking implants out forever, because every time you take the implant out, you lose a little bit of the bone.
Makes sense.
And so that's when we get into these salvage cases where we don't want to remove the implant. But if you don't remove the implant, you're not going to get rid of the infection. And so that's when you're now on lifelong antibiotics.
That makes a lot of sense.
But if that bacteria that you have, like Pseudomonas is a great example. There's a number of strains of Pseudomonas where if you have an IV antibiotic, it'll be sensitive to that. That antibiotic only comes as an IV. But it's lost resistance to one of the few oral antibiotics that'll work against it. And now you have this strain that you don't have an oral antibiotic option anymore. But you can't take the implants out, so you're sort of stuck. And that's one of the places that we've started using this phage therapy under very, very specialized conditions.
Oh, cool. How do you administer it if not with an IV?
IV, and we would just inject it right into the joint.
So you just give it to the patient and they learn how to inject it?
No. Yeah, you do it. So actually, one of the fun things with bacteriophage is it's like the pharmacokinetics for it are completely different, right? If I give you a dose of antibiotic, it's going to slowly be filtered out by your kidneys, and it's there for most antibiotics. You dose it over some course of a day, right? There's other antibiotics that stick around a little bit longer, but you do it. Am I doing this once a day? Am I doing this twice a day? Am I doing 3 times a day? With bacteriophage, it's a virus. And so it makes itself.
Oh, cool.
Right? Yeah. So if you inject it in the joint and it sees some bacteria, it kills the bacteria because it's making a lot of itself. It lyses the cell, the bacteria. That's how it kills it. And now you have a whole lot more bacteriophage that go along to somewhere else.
Nice.
And so theoretically, it's there for a while.
So pretty much until it does its job in theory, and then once all the bacteria is gone, that's its host, and then it dies off itself.
Yeah, but what it looks like is happening. You never for the few times that we've done this, it's more of I call it like a detente, right? It gets rid of most of the bacteria, but it's never going to get rid of all of it. Like it's a predator prey model, right? Because these have evolved together over a very long time, and so you don't get rid of all the bacteria, but you're kind of holding the bacteria at bay. And, so actually one of the fun studies we did, when you looked at this person's synovial fluid, it was a few months after they had the bacteriophage. And you could tell you have bacteriophage because if you have a plate of bacteria, so we call it a lawn on a petri dish, if there's bacteriophage in there, you put a few drops out, you'll get these, we call them plaques, right? Because that's that one little area where the bacteriophage was killing all the bacteria, right? And so if you dilute the bacteriophage down the right way, you figure out how many particle forming units you have in that milliliter by putting it across a plate of bacteria. And look, we have these plaques, and so you can then back calculate the titer of your phage. If we took the synovial fluid out of the patient and you put it on the plaque, you got put it on the agar plate, you actually got these little plaques, right? And so this is a few months after the fact, you still have some phage floating around because it's making itself.
Months later.
Yeah.
Okay, that's pretty awesome.
Now, and then you try to do it again. Now, if you do it systemically, it usually gets filtered out by your blood, or it's just going to get diluted out at some point. But the pharmacokinetics for it are going to be a little bit different because it's making more of itself. But it's really new. It's an area of medicine where it has a lot of potential, but it's also really complex to get it to work well. And so. And we don't know enough about it yet. So you need to do there's so much work in terms of, even just doing good randomized control studies, that's sort of the next big step. There's one company in orthopedics that did some of this, but it's getting much higher levels of evidence to truly understand, where is it working well and how can we use it and how should we dose it and all this other kind of stuff.
That's awesome.
Yeah, that's a lot of fun to work with.
That sounds like it.
Yeah.
Well, it almost sounds like it probably stays around longer, the worse the infection is, and then dissipates faster once the infection's died down a bit, or is that a misconception?
Nobody knows.
Nice.
Yeah.
Well, that's awesome. New frontier.
Yeah. No, it's something that we've known about forever, but it's become a much more as bacteria have become more as we're starting to encounter more different types of strains of bacteria where you don't have a lot of good options for antibiotics. There's been this sort of, it's kind of like rediscovering the past of there's this really valuable tool that we don't know enough about, and trying to figure out how can we use this and to put it into our arsenal to kind of help everybody out.
Awesome. What does it look like to get something like that through FDA?
Very, very difficult. So hopefully there's nobody from the FDA listening to this. So many pages of paperwork. Oh my goodness.
I don't know a single person that's put something through FDA that hasn't said that.
And importantly here, there's a good reason behind it, right? You want a very rigorous process to make sure that you're not missing any details, because this is about patient safety, right? And so it's balancing coming up with new ideas and being innovative to help people out, but minimizing the risk that you're exposing people to. And overall, the system actually, even though it can be very, very frustrating to work with, that's a good thing because it's designed well enough that it's I think of it sort of like a pyramid, right? You come up with some ideas and you do a lot of testing before you ever go into a human to make sure it's as safe as possible. Right, so you're doing all this stuff on the bench. Look, it looks like it's safe. Okay, so now we're going to take this into different animal models. Look, it's safe. We're all these different, and it's lots of standardization of we're going to use this model and this model and this model to show these different areas of safety. And then you use it on a really healthy patient, a very, very super low dose, very carefully escalating what you're doing, right? And then all this, a really well standardized test of these are all the things that people are going to be looking for to make sure that it's a safe thing we can do. Okay, so now that it's safe. So now let's look at efficacy, right? And we're going to use it on a small group of patients. And do we see a signal that this works well? Okay, yeah. And then that allows you to design your a larger clinical study where, look, we think our efficacy is going to improve things by, I don't know, 30%. But to do that, we need a study of this many patients. And as you're going along, you're learning sort of like the care, because no drug is completely safe. So you're looking like, these are the adverse events that we need to be looking for. Like, this is where we tend to run into issues with this. And so it takes a lot to learn all that kind of stuff. Like the one new class of antibiotics with, it's been a very slow, regimented, very methodical way to approach how they do it. I've learned a lot seeing that team put this together because they're very smart on how they're doing it.
That's awesome.
Yeah.
It's really interesting. There's only one thing I've worked on so far that's currently going through FDA, and it's the little bit I know. It's an arduous process, but to your point, I mean, like, the anecdote that I heard a while ago that was really interesting to me was that, like, thalidomide, the medication that caused a lot of birth defects that was there for morning sickness.
Oh, yeah.
Actually never made it through FDA's. So all the cases of thalidomide deformities were like Canada and like other countries where they approved it.
Oh, wow.
But because our process is so draconian, like we didn't really have those as much in the States. So I thought, and it's like, all right, there's a reason why we did that, I guess. Even if it's a pain in the butt to develop something new.
Yeah, it's such a fine balance of, we want to. It's all about, like, this is one of the important things in medicine, is about, like, a really important thing that you learn along the way is the decision-making process. How can we do this so that we've made it as absolutely safe as possible, but we're still being innovative and to improve outcomes? And it's a very fine balance so that you don't run into because in orthopedics, like, a classic issue with this was metal on metal, right? So back in 2000. The biggest problem with a hip replacement is that the liner would wear down because it was made out of plastic. And you'd have implants loosen up because the plastic particles would basically end up stimulating bone resorption, right? So then the implants would become loose, and these were really, really hard revisions to do. And so at the time, there were two sort of new strategies of how would we fix this problem. One was metal on metal. So, instead of having the metal contact a plastic where it would generate plastic debris, the machining had gotten to a point where the metal could be with a piece of metal. And you don't have any plastic particles, and so that should solve the problem. At about the same time, there's groups up in Boston, they came up with a new type of, they basically modified the chemistry, the polymerization for making the plastic. They basically, the plastic
cross-linked ultra-high molecular weight polyethylene.
Yeah, but now it's highly, before it was ultra-high molecular weight polyethylene, now it's, highly cross-linked ultra-high molecular weight polyethylene. And, so they kind of came out roughly at the same time. And it's like, well, which one's better here, right? And so they went through all these early steps to make sure it's safe in the animal model, like in the lab, and then in the animal models, and there's all these standardization techniques for looking at, like, what are the wear particles going to be. And then, you're doing this, you prove the safety in the animal models. And then, so now you take this into humans, and you start with a very small group and you follow them, and then you kind of expand your indications from there. And for the metal on metal, like, actually most people thought that was going to be the great way to go with this. But then, like, a decade later on, 2009, 2010 is when, if you type in metal on, like, a hip replacement problem, you still get all the legal ads because it turns out.
Oh no.
Yeah, no. So from the metal on metal perspective, you'd have these small little areas of corrosion, and it would generate these particles that we call adverse local tissue reaction.
Is that like galvanic corrosion that you'd see because of dissimilar metals or something?
No, it's actually so some of it, initially on the metal on metal, they thought it was from the actual triviology of the metal, like literally rubbing on on the cup. But then they also realized for, like,
and the
some
cup
of
was also metal in this.
Yeah,
case?
exactly. So it's literally metal on rubbing on metal. So you generate these particles. But even if you didn't necessarily have metal rubbing on metal, like, there's this other, it's mechanically assisted crevice corrosion in these very sort of like tight little, like, we have these machine parts where they get a very, very tight fixture. And so you have these very special kind of chemistry properties going on in there where you generate these these, you'd see these are made of cobalt chrome, and you'd see cobalt levels of blood go up, and it would generate this soft tissue response that would really be a hard thing to fix. Now, and this was a small part, like the majority of the metal worked really, really, really well. However, you'd have this small population of people that would run into a problem where they'd have really big issues with the soft tissue around the implant. And, at the same time, you had this group with the highly cross-linked polyethylene, also slowly marching along. And, at that point, they were a decade out from when they first introduced the highly cross-linked polyethylene, and the revision rates completely stopped for the polyethylene wear, completely stopped. And, it's really changed how we did hip replacements.
That's awesome. So the metal on metal, it's interesting because it sounds like the reason why this arms race started in the first place was that the non-cross-linked ultra-high molecular
you had a problem.
polyethylene was ablating and causing particles that were screwing up, tissue regrowth. And then the metal on metal, it was the cure to that, but then it was also ablating, and now you've got this cobalt that's going everywhere.
Yep.
Screwing up
and
tissue.
As you solve one problem, you find new problems. This is kind of getting back to what we were talking about. This is classic engineering. Yeah, right? And it was
whack-a-mole.
Yeah, so the metal on metal overall worked much better than the older technology. But there was this new problem that we had to learn sort of how to handle. But, in response to this as well, you're seeing this other technology, and it had even less of a problem. And so, and there's areas where the metal on metal worked really well. But it's that small group of patients that ran into the problem where it's really kind of fallen by the wayside because of that. One of the really interesting things with that development, and only because we're here in Pittsburgh, so it was actually interesting, and only because one of the classic surgeons up in Boston came out of the Pittsburgh. They were actually doing a lot of work up in Pittsburgh on the, it's sort of got beaten out the last second for how you make the diagnosis for this. And then up in Boston, it was a really easy way to come up with the idea. It worked really well. And look how much, this is where engineers in solving problems really make a difference, because look how many thousands of people they've helped out.
Awesome. So you're, just to take a step back, Pittsburgh versus Boston here. I got a little bit lost, I'll be honest. So you're saying that the plastic approach came out of Pittsburgh and the metal on metal approach came out of Boston?
Oh, no. Yes. People were trying to figure out, why are we having all these issues with the plastic, right? And actually, the person that initially made this was I think it was actually over on the West Coast. But it turns out that there was a lab up at Carnegie Mellon that was kind of looking at the same thing and just found it just a little bit later than the group out in California. In Boston, they were the people that came up with the idea of, wait, if we just take the same plastic we were using, but just put it through this extra step and highly cross-link it, it's going to work way better.
That's awesome. Yeah, and I mean, we all use that technology now. I mean, even outside of medicine, because it's such an awesome material.
Well, it's hip and knee replacements is actually also a really good analogy for engineering, right? Because initially, hip replacements came on the market a little bit before modern day knee replacements, and a hip replacement will work. When it got started, you were in the hospital for almost a month. And, you can't do this. And we were only going to do this in the much elderly patients because you don't have a lot of options if we run into problems, and you could be really stuck. And when you look at how the field has progressed, now the majority of my hip and knee replacements, we let them go home that afternoon. And people are like, well, how do you do that? And it's because over the course of decades, you have all these engineers working on better ways to make the implants or better types of instrumentations to change how we put the implants in, right? And the surgeons, we're figuring out how do we preoperatively, how do we plan better? If you have a patient, how can we really make sure that they're optimized as much as possible so we avoid problems? When we're in the OR, what can we do to minimize any complications that we're seeing and improve our technique? And then when you're out of the OR, what can we be doing to improve the recovery process? And every year, it's like crowdsourcing. You have all these people trying just a little bit of some different variations on what we're already doing. And you figure out, oh, this works really well. And so that gets adopted by the field. And then 2 years later, like all the little different variations from that approach. And all these tiny little changes really add up in a decade to make a big difference. And then it's 2 decades later, and so, hip replacements worked really well initially, but we're so much better at them, and they do a whole lot better now because of all these small little modifications that it's like the ultimate open source engineering.
That's really cool. So it's like the opposite of death by 1,000 paper cuts.
Yeah.
It's improvement by 1,000.
Yep. It's just like all these little changes and figure out what works and what doesn't, and sharing all it. Because my background, like over at Carnegie Mellon, was a lot of open source software stuff. It's the best example of why open source works so well.
I don't want to keep you here all day, but I guess as we kind of near the end of the episode, actually, I do want to keep you here all day. I'm lying. This is a fascinating conversation. I just feel
it's
bad
always
and
fun
want to
talking with you
about
about
family.
This stuff. Yeah.
But is there anything you want to plug? Is there anything you want, kind of people to take with them, projects you're working on? I guess just, things that you want people to just take away on the tail end of the episode.
Actually, no. So nothing to plug except for, this is like you stand on your soapbox. You don't realize what you have until it's gone. And so, a lot of the people I talk to, it's, gosh, like I used to be able to do this and I used to be able to do that, and I can't do it anymore. And, I kind of joke around that, the medical students will complain about walking, from like one end of the town, like, they'll complain about walking a few blocks to get to the other part of the hospital. Right? Because, oh my gosh, I have to walk so far. It's like half a mile. Where like the people I talk to every day would give anything in the world to be able to walk a half a mile and not have it bother them. So if you're going to walk away, if I have to plug anything, is the ability of like taking care of yourself and appreciating like what you have while you're still young, or you can still do it, because you're not going to have it forever.
I love that. Appreciate what you got. You're not going to have it forever. Ken, thank you so much for coming
Thank
on.
you, man.
Thanks for joining us today. If you've made it this far, chances are you'll like other episodes too. Collaborative with Spencer Krause can be found on YouTube, Google Podcasts, Spotify, Apple Podcasts, Pocket Casts, and Radio Public. Subscribe today to get notified when the latest episodes release, and support the channel. Have an idea for a guest I should interview? Hop in the comments and let me know who that is. I'm always looking for new people to talk to, and chances are you know folks that I don't yet. Thanks for coming in, and I'll see you on the next one. Collaborative with Spencer Krause is sponsored by SKA Robotics. If you're in the market for elite field robotics expertise, please consider hiring SKA Robotics. They sponsor this podcast and solve some of the toughest engineering problems in the world. SKA Robotics can be found at skarobotics.com.